As somebody who has looked at people who have treatment refractory illness that goes on for years, if not decades, and they come out with this sense of lightness. I'm getting chills talking about it. And they say to you, I feel differently. As a provider, it's powerfully moving.
This is Sick Health with Kevin Ban, MD. Our show helps you navigate our confusing healthcare system so you can take control of your own health. I really love this episode today. My guest is Ben Yudkoff, and he is the Chief Medical Officer over at Lumin Health. He's also the Medical Director of Interventional Psychiatry at Brigham and Women's Faulkner Hospital, where he's also an instructor of psychiatry at Harvard Medical School. He trained there. He currently focuses on treatment refractory psychiatric illness. And we went deep today. He had me into neurons and synapses and glutamate, but we were able to bring it up and really come away with what's important about ketamine. Who's the right patient for ketamine? What can you expect as a result of ketamine therapy? I really enjoyed this conversation, and I hope you do too. Ben, it's great to have you on the show. I've been looking forward to this conversation. Ketamine is one of those things we hear about all the time in the media, and today I'm really looking forward to our deep dive.
Great to hang out with you, Kevin. There's probably never been a better time than right now to sort of talk about the medicine. It's now in popular awareness. There's a lot of things happening in the media around it.
I met you a couple of years ago now. A mutual friend who's a professor at Harvard Medical School mentioned these guys who were using ketamine successfully to treat refractory depression. And I just had to meet you. And so I will say that so that the audience knows about it before we get started, that I am an investor in your clinical practice because I loved it so much. We met 2 years ago and I just thought to myself, I want this in the world.
Yeah.
And so I joined as one of your investors, and I'm so glad that I did.
We're happy to have you on for the ride. It's been great getting a chance to know you over these past few years.
I love to start with people's backgrounds, where they've been and how they got into their current practice. But you were just loving every day. So tell me more about why.
Yeah, it's fun. So my background is in treating treatment refractory psychiatric illness, depression, bipolar disorder, schizophrenia, OCD, and so on and so forth. In the world of meeting people who haven't gotten better with standard treatment, there's a certain leveled anticipation for how much what you can offer can provide. And so you're always conscious of the fact that things have not worked, and it's not as if you have a magic bullet. You're just trying to apply best effort. But the world of ketamine has proven to be something very exciting. For a subset of them, they really make a huge turnaround and their lives come back to them. And so as a result, every day the labor of my hand, directly or indirectly through the construction of these medical practices, is really designed to be to people's benefits. Every day I get a chance to either meet patients or help facilitate medical practices that are meeting patients. I love the work. I'm excited by it. Right now, life is moving very quickly. I enjoy going to work every day. I think, Kevin, I was telling you, I had to go into work for a few weekends, which normally would create a sense of lamenting my existence, but it wasn't that way. It's really gratifying.
Right now, you and I are having a conversation, and this is audio only for the audience, but I'm looking at you and you light up. And it's the reason why I wanted to be a part of this journey, because it can be so life-changing for people. And yet it has to happen inside of science. It has to happen with the right protocols and guidelines. We're going to get there. But before we get into what ketamine treatment is, why don't we talk a little bit more about treatment refractory depression?
Sure. Treatment refractory depression is a loosely defined term that encapsulates people who have tried to help their depression through the provision of medical services and psychotherapeutic services who haven't gotten better with standard care. The world of insurance companies have also lent a heavy thumb on the scale of defining what this term treatment refractory depression is. And so if you look at meat and potatoes practical definitions, we're talking about depression that fails to respond to between 2 to 4 antidepressant medications.
You're talking about medications now. And so it's the failure to respond to 2 to 4 medications. That is what the insurance company is going to look for. But there are other treatments for depression. We have electroconvulsive therapy, ECT. We have TMS, CBT, a bunch of acronyms. We can go deeper into what they are. So how do they fit into that?
Yeah, as people became increasingly aware of this thing called major depressive disorder as a phenomenon and some of the difficulties in treating it, and then on top of that, some of the consequences of untreated depression, including things like lost wages, lost educational opportunities, difficulties in relationships, not to mention the host of other medical illnesses that are exacerbated by untreated depression because a person may not have the wherewithal to care for oneself. People started to look into a host of things that might return a better yield in terms of treating the depression itself. So we'll start with ECT. So ECT stands for electroconvulsive therapy. Psychiatrists do not have marketing people. The terms electro and convulsive arguably should not be that close together in a statement unless you're actively trying to frighten people off. But ECT comes from an era, the 1930s, when people had erroneously observed that those who had epilepsy or seizure disorder were less prone to psychotic illness. At that point in time, people were looking into trying to cause seizures to people to treat illnesses. At that point, how psychiatrists were framing illness was still loose. The conceptual framework was loose. And so a lot of what looked like psychosis and depression, things were blending together. So people were using all kinds of things back in the 30s to elicit seizures. It happened that electricity was the safest and most predictable. And so what ECT is it's using these pulses of electrical current to stimulate brain cells, which are called neurons, to hyperactivate them. And what that does is it puts the brain cell under stress. It's like physical therapy for your brain. So you're hyperactivating all these brain cells. And just like if I were to go to the gym and put stress on a muscle cell, that muscle cell would say, hey, wait a second, I haven't been tasked with doing that before. I need to grow and get stronger and make sure that I can meet the demands that are placed on me. In a similar analogy, when a person undergoes ECT, those brain cells are getting stressed and the brain cells say, boy, isn't that something? If this is going to be part of what's tasked of me, I better get more efficient. And so there are a host of downstream things that happen to the brain cell, just like a muscle cell that gets exercised, that helps the brain cell become more active, more capable of performing its job, which is the production of thinking and mood and so forth. ECT has been with us for a long time. It's gone through a number of different cultural appreciations predicated on how society at large saw psychiatry. At one point, there was concern, not unjustifiably, that psychiatry was sort of a tool of the hegemony to standardize and call as illness or as disease things which weren't, just dispositions that stood outside of social norms. And so people saw psychiatrists as being a form of aggression against the value of autonomy. And they saw things like ECT as being the most aggressive version of that. And so ECT carries with it a legacy that we're still shaking off, and it remains the strongest treatment for treatment refractory illness.
In fact, it's one of those treatments that we fear a great deal. I think in part too because of movies like One Flew Over the Cuckoo's Nest comes to mind. The damage that was done probably in that movie to ECT is alarming. However, it's very effective as a treatment.
Yeah, an 80% response rate.
80% is very, very good. If you're in the 80% range, that's a good place to be. Let's touch on TMS and CBT, sure. And then I'm going to move us along, but I think it's helpful.
Yep. So TMS stands for Transcranial Magnetic Stimulation. It was FDA approved as it 2009 or 2010, right around there. ECT is a global treatment. It's treating all the brain cells indiscriminately. TMS is really a different kind of treatment. So in TMS, the entire magnetic strength of an MRI is condensed down to around 1 square centimeter, and it's just strong enough to stimulate a portion of the brain called the dorsolateral prefrontal cortex, a thin layer of cortex, a thin layer of brain cells. This portion of the brain does not directly produce what we call emotions or mood, but what it does is it has these tendrils that reach down deeper into the parts of the brain that do produce these feelings for us. And by repetitively stimulating this portion of the brain, among others actually for different kinds of illness, you can sort of enhance a connection and enhance a relationship between the parts of our brain that regulate what we feel and the parts of our brain that produce what we feel. This is going to come up as we talk about ketamine too. Our brains, just from the point of how we developed, are functioning in this weird tension between parts of the brain that are very primitive, that fish have and birds have. And as we've come up through the evolutionary tree, those portions of the brain haven't been substantially revised, but they've been added to. And so we see these relationships, sometimes these tense relationships, as different parts of the brain are trying to help us perform. And so what TMS is doing is it's playing with that duality of touching, one could argue, the more human parts of our brain, the more primate parts of our brain, to reach down to these more primitive centers, It's repetitively stimulating this portion of the brain called the dorsolateral prefrontal cortex to reach down deeper and to strengthen its connection with other portions of the brain with the hopes that it can better regulate those portions. You'll see, based on the literature, a fairly wide spectrum of response rate for TMS, but I think squaring up between 40 to 60% response rate is sort of a safe territory. The two big advantages to TMS over ECT is it doesn't carry this legacy of aggressiveness or otherness. And TMS doesn't require anesthesia like ECT does. And so people can build it into their daily practice. TMS is a daily practice. It's 5 days a week, 6 to 7 weeks at a clip to see if you get a benefit. TMS works where standard treatments haven't. And for a lot of people, finding an hour of their day to drive to a location and receive a 3-minute to 30-minute treatment and drive back without much in the way of side effects is a really helpful alternative to just spinning a wheel and trying another medicine.
It's really a commitment, though. That is the thing about TMS. I love how you're describing all of these therapies and how you think about psychiatric disease. One of the things that's interesting that you just pointed out to me is like when you talk about focused, you mentioned the word like MRI, it feels very cutting edge, right? Where somehow ECT feels the exact opposite, almost barbaric at times. That is not true. These are effective therapies and they're part of the armamentarium and important for psychiatrists to consider, especially for those who have not responded to medications, which brings us into CBT.
Yeah, so CBT stands for Cognitive Behavioral Therapy. It was developed in Philadelphia by Aaron Beck. CBT is remarkable in that it's probably the most medical of all of the psychotherapies. Medicine seeks to identify symptoms, identify root cause, which we call illness, and then apply a treatment that specifically addresses that root cause. CBT functions in the exact same mindset. It was developed by a physician, a medical practitioner. CBT seeks to look at how thoughts, feelings, and behaviors create this mutually impactful relationship that results in discomfort. Say in this conversation, Kevin, if I think to myself, man, Kevin really doesn't like me, I'm going to experience this conversation as being fraught. And my emotional experience will be anxiety, depression, a feeling of personal diminishment. I may live my own experience through what I anticipate your experience of me is. So a CBT therapist is getting at some of these core ideas and saying, well, let's look at the evidence. Let's examine this, and then seeks to apply a diagnosis from a non-judgmental standpoint. And well, maybe Kevin doesn't actually dislike you. What would be the difference? What's the evidence for and against? That's a hyper simplified version, but it's really meant to get a person thinking about all the thoughts that support the unwanted feeling, to critically evaluate them and see if there are ways of understanding some of the same perspectives differently. It's very practical. It's not deep dive about a person's early childhood experiences. It's really meant to say, what's happening right now? How can we apply these corrective measures? It takes a ton of motivation on the part of the patient. This is not a sit back in your chair and ponder kind of psychotherapy. It's an active psychotherapy. And its results in terms of both as a standalone psychotherapy for depression, but also when used in combination with medications is really remarkable. A course of CBT is 3 to 6 months. It's not necessarily a years-long thing. And in our world of justifiably wanting to feel better, not in 2 to 3 years from now, but now, CBT offers a much expedited recovery when you compare with some of the other versions of psychotherapy, especially the older ones.
I've talked about it before on the show when I spoke to John Cronin about sleep issues. CBT is very, very effective in helping people overcome insomnia as it is in helping people with a psychiatric disease. Ben, that's a really helpful summary of treatment for depression. You talked about medications. You talked about ECT, electroconvulsive therapy. You talked about TMS, transcranial magnetic stimulation, and of course, CBT, cognitive behavioral therapy. The one that I promised today and the one now that we should introduce is ketamine. I'm an emergency physician and I used ketamine for sedation. So when I wanted to do a procedure often for a patient, I would use ketamine. So when I heard that ketamine was being used for depression, I had to scratch my head and be like, what? Like, how does that make any sense? Because I thought of it as this dissociative medication that put people somewhat into a trance, but for the most part, was stable. And when a doctor says stable, it means that their heart rate, their breathing is stable. But I really thought of this as a medication I used for procedures.
It's a great way to kick in the door of what ketamine is. It starts its life as a dissociative anesthetic. And what that means is that it's an anesthetic agent, so it helps put people to sleep. And the dissociative part is important. The dissociative part has to do with how it disrupts the process by which we are aware of our surroundings. And so it disrupts that process of our awareness of our surroundings and helps us fall asleep. And as you note, importantly, and unlike a lot of other anesthetic agents, it doesn't at regular doses have a strong respiratory depressant effect, meaning it doesn't slow down breathing. Anybody listening to this podcast will call to attention some of the horrific deaths of people who have been given ketamine in the field. And so we'll qualify that in controlled settings, in monitored settings where people aren't in other ways injured or haven't otherwise ingested other substances, ketamine typically spares respiratory rate. So for an ED doc who's trying to set a bone real fast or manage an emergency situation, you wouldn't necessarily need some of the same equipment that you would if you were having to intubate somebody or help them breathe when they were asleep because of the medicine. Ketamine gains FDA approval in the very early 1970s for use as a dissociative anesthetic. And very quickly after its development, we start to see psychiatrists across the world writing about its potential to modulate mood. People were coming out of anesthesia feeling differently. People who were drinkers were developing different relationships to their alcohol consumption. Things get very quiet for a very long time for reasons that I don't know. And it's not until a chance encounter with a psychiatrist and an anesthesiologist on a train in Cleveland that the story gets picked up again. That leg of the story really begins when there was a second look and a bit of a deeper dive into the pharmacology, or what's called the pharmacokinetics, how the medicine plays in the brain on different kinds of receptors and how that play is different depending on the dose of the medicine. The first publication about ketamine and its use in helping someone who had suicidal thoughts comes out in 2000.
Well, I'm going to stop you there for one
Sure.
second and just ask you, like, very practically, when did you finish training?
2014.
Because I'm wondering how much of your training included the use of ketamine. So when did we first change the thinking? And then when did we really start adopting it, that we were educating our residents around its use?
Sure. So this wave of understanding really begins in 2000 when a doctor scientist named Amit Anand first started publishing on the usefulness of ketamine in treating suicidality and then by extension depression. There's a slow smoldering interest running throughout 2000 to 2010, 2012, and all of a sudden you start to see this real extraordinary look and the science becomes more rigorous and the number of trials becomes more rigorous. And it took about a decade to warm the community up to this idea that this medicine, which had either been known as a dissociative anesthetic in the world of putting people to sleep for procedures or as a club drug, it took a while to help people shift set and start to incorporate some understanding that this medicine could be used as a therapeutic. In my own training, there was very little. I think it was peripheral curiosity as something new, and people were starting to write about it. It was curious. It was sort of scintillating. There was an element of naughtiness to it because of the whole thing, and still things that we're dealing with today.
All that legacy, you're referring to Special K, and as an emergency physician, we talked about that all the time. And anytime you have illicit use of these medications, especially the ones that are psychedelic medications, that really undermines our ability to use those medications in clinical practice.
Yes, it does. It creates a justifiable hesitance. The modern pharmacopoeia, which is heavily impressed upon by standard Western culture, does not regard subjective experience as part of healing. It regards the medicine and its biological effect. When medicines like ketamine incorporate subjective changes in how we think and experience the world, or for some people, even the ability to experience a deep euphoria, typically we silo that under the heading of substance use or intoxication, not as medicine. And so there's a real careful high wire act that practitioners in my world are walking of trying to find ways of validating the myriad of ways in which these medicines are efficacious, including some of the changes to how people think, how people experience themselves, but to do so in a way which doesn't toe into the world of promoting wanton substance use or wanton intoxication, we should be making sure that there's no ambiguity in how we're promoting the use of these therapeutics. But it's complicated. This medicine that I could have used listening to house music in 1990s is now being used as a therapeutic. It leads a curiosity. And so we want to try to take that curiosity and shape it so it comes into a different kind of parlance.
Let's go a little bit deeper into ketamine.
Yeah.
Let's talk a little bit about its mechanism of action. I want to be sure that people understand that.
So I'm going to get us into the weeds of neuroscience for a second. Brain cells have a special name called a neuron. And let's hold that in our back pocket because it's going to come back. So when neurons talk to one another, the way that they do that is by sending a chemical. That chemical is released by one neuron. It floats across the space that exists between itself and all the neighboring neurons. And that space is called a synapse or connection. And then it alights upon a receptor. And so let's think an analogy. So as I'm talking with you, the sound of my voice is traveling across this electric chasm. It's coming out of your speakers and it's alighting upon your receptors, which if you could see me, I'm holding out my ears. And so it touches those ears. And then once the sound touches those ears, it causes a change in shape of the ear that helps the ear transmit that signal into the deeper structure of your brain. In exactly the same analogy, the chemical floats across the space. It touches the receptor. Again, the analogy to an ear. It causes a change in shape of the receptor, which then helps it transmit the signal into the deeper part of the cell. The chemical that we're going to talk about here is called glutamate. Glutamate helps to oversee lots and lots of different processes. And when glutamate is out of whack, we see lots of processes go wrong. So things like psychosis, seizures, changes to blood pressure, changes to heart rate, tremulousness, anxiety, insomnia, all kinds of things can happen. And so you have a very tight regulation on glutamate. This tight regulation is accomplished by another kind of brain cell called a GABA inhibitory interneuron. And what this brain cell does is it listens for how much glutamate the sending cell releases. And if it releases too much, it effectively sends a stop signal and says, whoa, buddy, that's enough of that. And so you have this sort of break in the system. And now we'll get into ketamine. So typically, glutamate, when it floats across the space between two cells, it alights upon several different kinds of receptors, but we're going to talk about two in particular. One is called the NMDA receptor, and the other is called an AMPA receptor. And both of these receptors are involved in processes related to learning and cognition, thinking. When ketamine is delivered as a high dose, like you might in the emergency room, ketamine comes and it blocks the NMDA receptor and the AMPA receptor on the receiving cell. So the receiving cell can no longer perceive glutamate. And if glutamate is a neurotransmitter that gets the brain cells excited, if you block the excitation, you get the opposite of excitation, you get sedation, and suddenly a person falls asleep. But a curious thing happens at low dose. So at low dose, ketamine preferentially binds to the NMDA receptor, less so the AMPA receptor. So it begins to block the NMDA receptors on the receiving cell, but leaves the AMPA receptor relatively untouched. And guess what? The GABA inhibitory interneuron, that monitoring cell that we talked about before, it also has an NMDA receptor that it uses to monitor the release of glutamate. At low dose, ketamine is also blocking that NMDA receptor. And so for a period of time, the GABA inhibitory interneuron is less able to perceive glutamate. As a result, it doesn't send the stop signal adequately. More glutamate is released, and you have some NMDA receptors on the receiving cell, and certainly the less occupied AMPA receptors, totally available to receive this extra glutamate. And so the extra glutamate hyperstimulates these receptors, which causes a ton of changes inside the cell, very similar to putting a small stress on the cell. And the cell says, boy, I'm more activated than I typically am. That must mean more is needed of me. And if more is needed of me, I need to start growing and reshaping how I do my job. And so it does that by releasing effectively a growth hormone. In this case, it's called brain-derived neurotrophic factor, or BDNF. And what that BDNF does is it helps that brain cell reach out and form new connections with all of the neighboring brain cells. We call that synaptogenesis, which people will read about, or sometimes people will call that synaptic plasticity. That's a term that's used for how fungible and moldable brain cells can be.
Well, you're doing a really beautiful job of explaining it. So what I'm going to do is I'm going to put it back at you, okay? What's really interesting about this medication is that in big doses, you sort of have that anesthetic sedation, but in smaller doses, you don't, right? But what you do have is that excitement of the neurons, similar to what you see in ECT. You have this stimulus to excite the cells in a way that they are now at the gym doing the reps that you talked about earlier. And that's why when people talk about ketamine changing the brain, I think you're here describing how that might happen. And it is here where you can have breakthrough. Am I tracking?
Yeah, you're tracking 100%. It's a great jumping off point to help correct a very common misconception for people who are reading about ketamine. So people will say things like, oh, the ketamine will induce this neuroplasticity, this growth of different connections in the brain. That's what's treating my depression. I think that is a ever so slightly false paradigm, and it's also an ever so slightly diminishing paradigm. The types of connections that are getting made, many of them are random and they may not be in support of a person's mental well-being. What this medicine is doing is it's helping the brain to mold itself to actively learn. If you take that enhanced proclivity to learn and develop and marry that to real meaningful psychotherapeutic, spiritual, behavioral changes that are trying to entrain new ways of looking the world, new ways of appreciating the world, new ways of being in the world, what you get is a very happy coupling. You get the brain's increased capacity to be and to mold and to learn and to take new deep perspective. And we're going to talk about that in a second, that deep perspective, as we go on to some of the other mechanisms of action of ketamine, its derivative esketamine. But if you take that enhanced proclivity and you couple it with not a passive position in the person who's availing himself, herself, themselves of the medicine, but an active position, what you get is a gassed up car with a driver who's ready to take it on the road. Not that I would promote the use of anabolic steroids, but if I took steroids and didn't go to the gym, I wouldn't grow muscle. I would still need to use that muscle, and the potential for my muscle to illicitly grow would be enhanced. I would still need to use my brain to actually get the growth that a person would want out of it.
I think that's really helpful to clear that up. But it does begin to help us change how we think about ourselves. Is that fair?
Oh, yeah. Yeah. I think that that's a great frame to think about the medicine and how it works for people.
I think that is useful for people to understand about this medication, that through the mechanisms you talked about, people have the opportunity to, in some ways, change even how they think about themselves.
Yeah, let's talk about that. There is no difference between neurology and psychology. They are functionally and fundamentally the same. But let's put that in our back pocket for a second. There's a portion of the brain called the default mode network. This is a really, really complicated network in the brain. And so when we think about the brain, we don't just think about specific nodes or one discrete area in the brain producing what we call experience. Instead, these nodes, these little areas of the brain, are working in partnership with many other nodes in the brain as a system to help produce what we call experience. And so in that way, we have this thing called the default mode network, which is connecting many of these different local areas of the brain to produce at least what I like to think of as the neurological correlate to the subconscious or unconscious. This portion of the brain, which is a highly preserved and highly primitive section of the brain, is really forming our early inchoate thought. And what it's doing is it's helping to qualify what we're noticing around us, whether it's good for us or bad for us. It's taking in information from, we call them interoceptive cues, taking information from how our body feels, our temperature, our heart rate, our blood pressure. It's taking information from the portions of our brain that hold specific memories that we have. It's taking all of this stuff, and it's synthesizing massive quantities of information. And it's helping us determine and qualify experience even before we're aware of it. And then what it does is it sort of delivers to our conscious self the parts that we would most closely identify with, the parts of ourselves that generate actual thought, semantic thought, words, images, that kind of stuff. It gives that portion of the brain essentially a summary. And then that portion of our brain that makes sense of things is going to interpret and produce a thought that correlates with that early formed perspective. That default mode network comes to contain a lot of what we think of as self. For listeners who are sitting in their living room, the awareness that you're sitting in the living room is being passively monitored by this default mode network. The fact that you're hungry is being passively monitored. The fact that the sound of a siren went off and that the siren has implications for when you broke your arm when you were a kiddo, and that's a slightly scary thing. And all of a sudden you feel anxious for reasons that you don't know. And so you think about the taxes you haven't done. It's keeping you connected to all of these experiences. And so when people have depression, and we're going to stick with depression for now, even though ketamine has been used in studies to treat other kinds of psychiatric ailments, when people have depressions, we sometimes see that certain nodes, those component local areas in the brain that come to comprise the default mode network, show some aberrancy in how they operate. Sometimes they're overproductive, and that can correlate with a sense of threat. What happens when ketamine comes into the system is it disrupts this network. We're going to leave the subjective experience for the last mechanism of action because I think that's the most philosophical. But in this disruption of network, a person is able to experience things without the same degree of standard habituated appreciation. And so, what do I mean by that? If I have a thought, and before that thought even exists, my brain is already appending a negative association to that thought. The interpretation is essentially built into the thought itself. But what happens if a thought or an appreciation of something does not come with the typical standard association? The brain is able to then take a more dispassionate, empirically based idea of things. And so people can come to different ways of understanding old ideas. Gosh, whenever I thought about my mother ridiculing me for being not enough for her when I was a kiddo, I always internalized that experience and appreciate it as evidence of truly not being good enough. But in this moment, when the ketamine is in my system, I don't have that automatic correlative appreciation. I don't have any judgment. I simply see it. All of a sudden, I might be able to see many things in that experience, in that recollection that I hadn't been, such as that was my mother's own stuff. It had nothing to do with me. Or couldn't also be said that I was unbelievably resilient as a kid without the intellectual or emotional IQ that I have now to deal with it. I can come to a different way of knowing myself. There are ways in which when the medicine is in the system and it's disrupting these networks, that when under the thrall of these medicines, a person can come to different ideas. And then when this network reintegrates as the ketamine leaves the system, what it does is it helps the brain better regulate itself and qualify whether or not it needs to judge early formed thoughts in a particular way. And so people may experience the world less pessimistically because they have that less naturalistic tendency to see the world through threat, because this default mode network is regulating itself better and actually paying attention to circumstance differently.
I'm thinking about what you're saying and trying to just make sense of it. Like if I had to explain this to my wife later tonight at dinner, how would I say it?
I think you would say that the medicine, through its action on the default mode network, helps to disrupt the brain's natural resting state to see the world pessimistically or negatively. And instead, it helps it adopt a more neutral approach.
Like it almost feels like the medication allows for a different lens.
Yeah.
When you're at the optometrist and it's like, okay, how's it with this lens? How's it with that lens? You get closer to clarity, right? And I'm almost feeling like this medication is a way to shift lens. And then the second piece, the follow-up piece, is judge it more objectively and less emotionally, or with less baggage somehow baked in.
That's it.
Oh, you're killing this because I'm really getting to the bottom of how this medication works. And you're doing it in a way that I found really interesting, which is you're coupling neuroscience with the subjective feelings that people are having as a result of this medication. And I find that fascinating.
So we've talked about changes to thinking, changes to the brain's ability to adapt and learn new skills. We said nothing about mood. Just a brief word on that. So ketamine touches these things called opioid receptors. Now, the same receptors that are touched on by opioids like morphine. But in our own brain, we have these chemicals called endorphins that we're familiar with when we vigorously exercise and we get what's called a runner's high, that sense of being uplifted. Ketamine can also help to sensitize the mu opioid receptor, and the brain cells will actually populate themselves with more opioid receptors to help them listen to these things called endorphins. And these endorphins are directly connected to mood. And then the final thing is really the psychedelia of it. We got to take 2 seconds and just talk about something, because people who get benefit from ketamine, they don't come out of these experiences and say, hey, doc, that enhanced glutamatergic neurotransmission was banging. What they say is, I saw colors. I felt the music. I felt a sense of mindfulness and oneness with the world. I lost my sense of self. The connection to that potential psychedelic experience, and it doesn't happen for everybody and it doesn't happen for every experience, happens to be the thing that people talk about most. And it's the thing that I take the most caution about speaking about, because I don't want to promote wanton intoxication, but it would be a missed opportunity not to talk about the fact that this medication can provide people these islands of euphoria who are otherwise feeling really lousy. They can provide an island of respite, 2 hours of peace. They can reintroduce people to moments and ideas that help them feel curious about their surroundings, experiences that can help them feel like there could be majesty and wonder in their world, and moments that can help them connect ideas that they hadn't been able to connect because of just how rutted thought patterns can become when a person feels just like crap. They feel depressed.
For a person who maybe can't get out of bed, can't shower, can't do the basic things of loading a dishwasher, this is revolutionary.
Yeah. Now, I'll be careful. It doesn't happen for everybody. It doesn't happen all the time. But as somebody who has looked at people who have treatment refractory illness that goes on for years, if not decades, and you see them come out of these experiences, at least some of them, and they come out with this sense of lightness. I'm getting chills talking about it. And they say to you, I feel differently. As a provider, it's powerfully moving to be in a helping relationship with someone in this kind of way. And as a person who's struggled for a long time, I can't imagine what that feels like, to take a minute to breathe and see the world so dramatically differently. It's really awesome.
That is nothing short of beautifully said. I want to go deeper into more practical issues around insurance. What's the difference between ketamine and esketamine, and how are they delivered? And, just some practical tips that people who are listening can walk away with. But before we do that, Ben, a word from our sponsor. C2 Sense is doing important work with its Halo platform, applying technological advances in chemistry, machine vision, and material science to provide both patients and providers with laboratory-level accuracy at low cost when they need it. C2 Sense's goal is to use their patented technology to ensure the same quality of testing you would find in your doctor's office in the comfort of your own home. So if you're suffering from upper respiratory symptoms like cough, sore throat, nasal congestion, or a headache, keep your eyes out for C2 Sense, as they're developing tests targeting upper respiratory conditions such as COVID and flu. If you want to learn more, see what they're up to at haloreader.com. Okay, let's do some nuts and bolts of ketamine, because I think we use that term as a catch-all, but there are different types of ketamine, at least in terms of how they're administered to patients. So let's start there. What's the difference between ketamine and esketamine?
Sure. So ketamine is the name for a molecule. So molecules that have 3 dimension have an orientation, just like your hands. You've got one hand that is oriented to the right and another hand that's oriented to the left. In chemistry, we call that chirality, or enantiomers, how these molecules can have mirror images. And so ketamine is an equal part mixture, 50-50, of ketamine oriented to the right and ketamine oriented to the left. And so what S-ketamine is it's just a distillate of the left-sided oriented molecule. The S in esketamine, it's Latin for sinistrum, which is where we get the word sinister from. So it's just the left-sided version. And it happens to be that the left-sided oriented molecule binds more tightly to some of the targets in the brain of ketamine. It also crosses something called mucous membranes. So mucous membranes are the pink skin that lines the inside of our nose, our eyes, our mouth. The right-sided molecule has a harder time traversing across the mucous membrane. So the left-sided molecule has an easier time, which is why S-ketamine is delivered as an intranasal spray or as a transbuccal lozenge. And a lot of the ketamine that's being delivered is the left-sided portion when it's given across a mucous membrane. But typically, ketamine is usually delivered either intravenously or intramuscularly. And so what we're doing is we're circumventing some of the mucous membranes and just giving the medicine right into the bloodstream. And your listeners may say, well, why can't I just take it orally? Wouldn't that work? And another issue comes up, which is that the liver, which chews up medicines or metabolizes chemicals, will chew up so much of the ketamine before it gets into our general bloodstream. We'd have to take massive quantities of ketamine, and that could be an issue for people.
You're talking about if you were to have some sort of pill or capsule that would go into the gut and there'd be a first pass effect, I think is what you're referring to.
That's exactly right.
And the first pass effect is going to deactivate most of that medication, such that, to your point, you would have to take so much to overwhelm the first pass effect that it's just not practical.
But there are people who are looking at pills right now, actually, and we'll see what comes out of those phase 2 studies. But it creates several extra steps in how the medicine is delivered, which may ultimately come to impact its mechanism of action.
What do you do in your clinic? Are you using ketamine? Are you using esketamine? And why?
I am not using ketamine and esketamine, but I'm overseeing its use.
All right, I'll tell a little story here. When I was teaching medical students and residents, all the time I'd be like, we're going to, and then we're going to,
Yeah.
and then finally we're going to. And then I would end by saying, and you guys do realize that when I say we, I mean you, right? So I'm using the royal sense of we. How does one,
Yeah.
to be more?
Yeah. It's a great question. So esketamine carries an FDA approval for the treatment of treatment refractory depression and for the treatment of suicidality occurring in the context of major depressive disorder. And so for people who meet those criteria, as well as a criterion of how severe the depression is. So if someone meets those thresholds, they're eligible for an insurance-covered esketamine intranasal treatment. Having said that, lots of our patients have depressions for other causes, like bipolar depression, or they may come with a diagnosis of OCD or anxiety or PTSD. Now, the world of ketamine and its use for the treatment of psychiatric illnesses is all off-label. And we need to take a second and just kind of honor that fact. We use medicines all the time in medicine across the board off-label. That nothing new, nothing special about that. But there is something unique to psychiatric conditions themselves and how they're socially regarded. And there's something unique about ketamine insofar as it does have this potential abuse. And so there's a greater hesitance or awareness of the potential risk of using this medication off label, even though I would posit it's not anathema to medicine at all. But for people who have conditions for which there is not insurance coverage, they will typically elect ketamine. And ketamine is then delivered as an out-of-pocket expense outside of insurance. In Massachusetts, there are some insurances that will cover the cost of ketamine, but they will only cover the cost of intravenous ketamine, not intramuscular ketamine or ketamine delivered by other mechanisms. And they will not provide insurance authorization for conditions outside of treatment, refractory depression, and suicidality. So it's a much more relegated insurance offering. Lots of people have hard decisions. And actually, it shouldn't, not just the patients, the physicians need to be thinking about the ethics of for-profit business and for-profit out-of-pocket expense. It is ethical and it is permissible for physicians to work outside the context of insurance, but it should stand in some awareness that some people need to choose between a cable bill or a phone bill, I mean, not to be flip, and a stab at treatment. And treatment is expensive. The treatments for a single clinic-delivered ketamine can run between $500 to $1,200 or $1,300.
And you're referring here to ketamine that is delivered through an IV.
Or intramuscularly.
Right?
Yeah.
Or intramuscularly. What about intranasal? Who's likely to be using intranasal ketamine? And can that be done safely in these settings or even at home?
Here it gets super confusing. There's intranasal esketamine. We're not talking about that, which has to be delivered in an FDA certified, REMS certified clinic. Intranasal ketamine, the same ketamine that's delivered intravenously as possible, as well as lozenges. And so a lot of people are prescribing them. I'm going to tip my hat and betray a bias. There's a reason why the clinics that I've helped to found, we don't do this. And it has to do with attunement to risk versus benefit. The benefit to intranasal ketamine is that it could be done at your home in the comfort of your own timing. And when you want people to get better, there is a justice in trying to make this medicine as available as it needs to be to help the greatest number of people. But we also live in a world that is still currently dealing with the opioid epidemic and the overprescription and overdistribution of medications that have a medical application but can also be abused. We are still aware that teenagers are getting medicines from their parents' medicine cabinets. We're aware that there's risk that overuse of these medications can lead to death.
And I'm going to point that out here, always threading the needle between trying to deliver care and harm mitigation. And I think you've referred now and alluded to a couple of times Matthew Perry, who was taking ketamine at home under circumstances that many would consider extremely risky. I feel foolish even saying this because of the fact that he died, but he was not taking ketamine in the controlled environment that you're advocating for. That's what I'm hearing from you, which is there are different ways to administer this drug, IV into the muscle, IM, or intranasally, even maybe at home, but we have to do it in such a way that it provides the most benefit and we mitigate the most harm.
Yeah, that's fair. So when we do it in a clinic, we're assessing vital signs, we're checking in with people. If people are throwing up, we're making sure that they're not aspirating or inhaling. So it doesn't happen that often, but it's a concern. We're also making sure that people are checking in about what kind of medications they've taken in the morning time to be sure that there are no interactions. Has a person recently been concussed? There's a myriad of things that come up that are impossible to predict all of them, but they become part of the living conversation we have with someone before treatment. Now, for the right kind of patient, it may be possible to deliver this at home, and with the right relationship with the provider, I think that there is justice and there is import in providing this medicine to people who are in need and trying to disencumber it to the extent that anybody can. That has to sit on an equivalent value of safety. And so the choices that we've made in our clinics is that we do them in the clinic and that we don't distribute them at home, just because as soon as you start doing that, the types of trouble that a patient can run into and the types of trouble that a doctor can go into really increases substantially.
We're on a journey here, and it's safe to say that we have to navigate this journey in a way where it's safe so that we can ultimately provide the most benefit, even if right now not everyone will have access to it. But I'm going to move us on simply because we must. There are some other things that I want to explore, like, for example, who's the ideal patient for this?
Patients who come should be prepared to engage a sense of curiosity. Sometimes we have to do things nervous, and so people need to be able to tolerate that. People need to be able to know or have some sense of intuition of what happens if I feel better. And that's an important qualification. So if the medicine, either ketamine or esketamine, works, it can really be quite dramatic. And a lot of people have been depressed or have been obsessional or re-experiencing trauma. They've been fettered by their experience for such a long time that they've built structures in deference to the struggle they're going through. When that happens, if someone feels better, that's great, but that's not going to call your friends you haven't spoken to in 5 years. It's not going to get you the job you had to leave because you couldn't show up to work. It's not going to re-engage you in your own church service or synagogue or mosque or whatever the temple service. A person has to be ready to sort of make the changes and accept the changes if they feel better. My own personal feeling is that it helps a person to be able to take a gestalt impression. A person needs to be able to get a sense of how am I feeling? How am I doing? Let me take a retrospective. Did I cry this week? That can be really helpful. And then also it's a pain in the butt, right? You've got to travel to and from a clinic. You got to deal with people like me. You have to take time off from work. So people need to be able to take time and actually engage, including sometimes if you have a strong experience, you got to be able to take a few minutes after the treatment's done and you're back on the ground again, just to have some time to process.
This brings me into the next thing, which is if I'm in the right headspace and I'm going to make this commitment, what can I expect for efficacy? both in terms of how likely is this to work and what can I expect if I'm getting better? Is this ongoing or am I ever, for lack of a better term, cured?
You'll see numbers a little bit all over the map. So ketamine, intravenous ketamine's efficacy is somewhere between 60 to 70%, and intranasal esketamine, we're probably looking at around 60%. One of the other big differences between ketamine and esketamine is we're very locked into dosing with esketamine. And some of the difference between the efficacy in esketamine and ketamine may have to do with the fact that we can simply deliver much higher doses and some people need it. Some people just may respond better for reasons that we don't totally understand to one versus the other. The question of durability of treatment is really complicated. So, in one model of thinking of depression, we think about them as chronic illnesses. And so, much like a cancer may go into remission and then may resurface and then you treat it again, there's some thinking that depression, among other illnesses, may have the same characteristic. I'm going to speak out of both sides of my mouth. The vast majority of the people who we see come in for regular maintenance treatments at an interval that makes sense for them. Most people start the same way. It's twice weekly treatments for somewhere between 6 to 8 treatments. That's a 4-week commitment. And then go on to a tapering course or pausing treatments for a period to see how they feel. Most people will come in intermittently for acute exacerbations of their symptoms, or they'll be on regular scheduled treatments to keep the worst of it at bay. There's a percentage of people, and I don't know what it is, who will come in for a course of treatment and something will shift inside of them, either a realization or they'll be able to engage a new behavior, or something happens where they're able to take something from these treatments, the change or an idea, and really it serves as an inflection point. They may have enough sustaining them outside of this particular treatment to keep the shadows at bay. It doesn't happen a lot, but when it happens, it's a really wonderful celebratory moment. I think the one thing to take caution for is that every doctor is basically making business off of people suffering, and it's held to a different ethical regard than a lot of other professional relationships because of the inherent vulnerabilities therein. And so a person needs to make sure that when someone is going for treatment, that the person who's recommending a treatment course is listening to them, is providing a rationale for why the treatment course is being recommended, for having some tolerance for a treatment course that the patient receiving treatment might prefer, and a willingness to engage slightly different models so long as it's safe. You want to keep your ear out for that to make sure that you're not just there as a way of filling a slot. And again, it's a very cynical way of thinking about it. And I don't think that doctors do that in general, but that's important to stay safe.
I think it's important to point that out for people who might be considering this type of therapy. And what I heard you say is, look, it's intensive up front. We land usually on a rhythm that works for that individual person. But the question someone ought to be asking their provider is specifically, why am I doing this now, right? Like if they happen to make their way into that wonderful experience of being better and God forbid even cured,
Yeah.
to continue therapy makes zero sense. I'm going to land on one more topic, but I'm going to want you back here, Ben, if you're willing to do it, to talk about more things, because there's so much. I want to, in a future episode, talk about inpatient clinics versus telehealth and everything the DEA is doing right now.
Yeah.
There was a big crackdown on telemedicine in particular, but even some clinics. We're expecting now in fall of 2024 that we'll have new guidelines and recommendations coming from DEA. So maybe that's the time that'll come out, and we'll come back and talk about that. But let's land on one last thing, which is bad trips.
Yeah.
I feel like we have to have some conversation because people think about it and they're wondering like, hey, what happens if I go in there and have a bad trip?
The number one impediment, the number one anxiety is what happens if I have a freak out. So and the first thing is freakouts happen very seldomly. It's a hard analogy between ketamine and other kinds of psychedelics. I typically say it's a different house in the same neighborhood. It's described as a fundamentally different kind of experience. It's much more internal. It's much more of a sense of floating and noticing. But sometimes that floating and noticing can take a person into hard ideas. So there are several moments when these bad trips can arise. So the first thing is that it's just part of the inherent chemical of the medicine. So the medicine causes something called the catecholamine release, or the release of these chemicals in the brain, dopamine and norepinephrine. These chemicals in the brain can hasten the heart rate and increase blood pressure. believe it or not, although you might not be conscious of it, the brain is tracking all of this stuff. And all of a sudden, the body is saying to the brain, hey, my heart rate's up, the blood pressure's up. The typical circumstance which that happens is one of anxiety. And so now the brain is starting to process anxious thoughts, starting to focus in on what's the cause of the threat. That can sometimes be mitigated by some slow, deep breathing to slow the heart rate down or to decrease blood pressure. Sometimes we can give medications in the middle of the treatment that can help to keep those values at bay. Sometimes a person just has hard thoughts. It's always important. I think you said this. For whom is this treatment? If a person is coming into care in any way, shape, or form feeling coerced, my therapist is telling me to do this, my family is telling me to do this, automatically you're on the wrong foot. A person has to be bringing this experience in autonomously. And this way, the otherness that occurs when the medicine is in one system is experienced as volitional exposure as opposed to semi-volitional. So you got to be careful that someone is going to be wanting this otherness. You have to prepare people for the suddenness of the otherness. This medicine comes in like the Kool-Aid man kicking through a wall. It just all of a sudden it imposes itself. A person has to be ready for that relatively quick transition. And there are times when with the best preparation and the best set and setting, with all the best intents, a person still may have a troublesome thought. When that happens, it's really good to have a care plan with your provider. And this is the reason why we do this medicine in the clinic. During those moments, we talk to people. We give them breathing exercises and visualization exercises. At Lumin, the clinic that I co-founded with my partner, we have consent for touch. We touch from shoulder to elbow, and sometimes touch can be a grounding force. But considering that many of the people we see also carry with them histories of trauma, we're always careful about who gives consent and for what. But touch can be important, calming conversation. And in rare circumstances, sometimes there can be a real existential struggle as a person is experiencing a dissolution of a sense of self, connection with space, or a difficult recollection. There's a world of psychotherapy that can be provided in the midst of one of these experiences, so long as it's done with great sensitivity to how inferences and meaning may be taken differently by someone who's under the thrall of ketamine and esketamine. But with caution, sometimes you can talk somebody into their experience so they can dialogue with it and see the troublesome thought as a teacher. Sometimes it's a teacher that's trying to show them something. Sometimes it's a teacher that's trying to trick a person into seeing something. And so engaging and dialoguing with the material idea or image of the bad trip can also be a fantastic way to sort of judo a difficult experience into one that can be profoundly meaningful for someone.
Wow, that was a great explanation. That is where we need to land. You have been wonderfully generous with your time. I have deeply enjoyed this conversation. We have gone all the way from the synapse up to insurance companies and whether or not they're going to reimburse. Let's land on a book or two that you recommend our audience if they'd like to learn more.
Yep, there's a ton of books out there. The ones that I see a lot of people vibing off of, there's a book called The Ketamine Papers by Phil Wolfson and Glenn Hartelius that presents a lot of great information. It helps to bring in some of the concepts, kind of like we were discussing here around the science and also the room for transformational experiences. I have nothing to do with these books. So here's our honest recommendation. And the other one is, so we use a few different ketamine preparation and integration workbooks for people who are undergoing treatment to bring in some of the care to their own convenience when they want to work on things or think about things. And one of the books that we use is written by someone named Stormy Brannon, and it's a book called The Ketamine Preparation and Integration Workbook. And these books can help people set a mode or intent, a purple hum, something that brings them into the experience of both the treatments themselves, but also just the process of the sequential treatments in a way which helps them wring as much out of it as possible.
Ben Yudkoff, thank you so much. I know a lot more about ketamine therapy now than I ever did.
Good.
Thank you for that.
It's an area of passion, and it's become the totality or the near totality of my professional experience. Thank you, Kevin.
And thanks to all of you for listening. I want to hear your thoughts about the episode. Do you have any questions? Are there topics that I should cover? If so, please leave them in the comments below, and I'll do my best to answer. That's our show for today. The show was produced by me and Batsheva Gez. Until next time, be well.